Recording.
Good evening, everybody. It's a pleasant task for me to talk to all of you about the topic, which is in the post-COVID era, a hot topic about, especially when we're managing the acute respiratory failure (ARDS) patients. And this is ECMO, but the better term that we like to use is extracorporeal life support. So my objective is that I wanted to run over the present indications, what are the various evidence for those things, and the cost implications and how we go about it. We all know that almost 2 million people with acute respiratory failure are hospitalized annually in the United States with a cost exceeding 50 billion. And if you now include the COVID, it's going to be significantly high. The acute respiratory failure is probably the number one working diagnosis for all of us in the last 6 months in the intensive care unit. About half of them used to require invasive mechanical ventilation, and the in-hospital mortality used to exceed 20%. But again, in the COVID era, we would say that we are, of all the ARDS, we're getting away with a lot of HFNC and a lot of non-invasive ventilation, even when the PF ratios are less than 150, and we are reserving the ventilation for severe patients or for failure using a ROX index and things like that. So again, mechanical ventilation, however, we've seen is in the past also and recently that there is a significant downside to it, and that includes ventilator-induced lung injury and ventilator-associated pneumonias and other infectious complications and multi-organ dysfunction. So the mortality of patients with respiratory failure on mechanical ventilation continues to be not significantly improved, but still it's been a great progress since the polio epidemic. However, we're looking for newer ways to do things, and the extracorporeal life support basically means the application of technology like the heart-lung machine to sustain a life beyond a critical stage of illness. Once your native cardiopulmonary system is unable to do it or it completely ceases to do it. So, like for instance, even in a code blue situation where you have a cardiac arrest, nowadays ECLS is considered as a technology to sustain life at that particular point. So ECMO is one of the terms which is a part of an overbearing system to talk about extracorporeal life support, and it's a circuit that directly oxygenates and removes carbon dioxide from the blood. By definition, when we say extracorporeal, that means outside the body. So it is something which is happening outside the body instead of inside the body. And the extracorporeal life support, as I said, provides gas exchange via an extracorporeal circuit, and it provides support to a failing lung, a failing heart, or sometimes even both is has been required in a cardiogenic pulmonary edema and a cardiogenic shock. The terminology wise, ECLS or extracorporeal life support is broadly divided into two terminologies: ECMO, that is extracorporeal membrane oxygenation, and extracorporeal carbon dioxide removal, that is ECCO2R. The ECMO can be of two types: veno-venous (VV) or VA, veno-arterial ECMO. And when we talk about extracorporeal ECMO per se, it is an overarching term for all forms of support. But the principle is that you have a blood pump, you have an artificial lung, and a vascular access cannula which can provide blood flows, which is at a rate which is not the CRRT rate or a rate which is required for dialysis, but a very high rate for oxygenation, and a rate which is much significantly low for carbon dioxide removal. And we will talk about these rates as we come along. So the first and the foremost is the VV ECMO, which is what is the predominant method of ECMO support, or ECLS, extracorporeal life support for acute respiratory failure, is the VV ECMO, wherein the extracorporeal gas exchange is provided to blood withdrawn from the venous system and you return it back into the venous system. And the flow rates are typically in the rate of 3 to 7 liters per minute. And obviously, this mode, because of the fact that it is only oxygenating and removing carbon dioxide, is for respiratory gas exchange only. So, VV ECMO is the modality of choice for an extracorporeal life support with in an acute respiratory failure, which is not amenable to mechanical ventilation or is refractory to mechanical ventilation. And we'll come to the indications later down the talk. A VA ECMO is also a situation where gas exchange is provided to the blood that is withdrawn from the venous side of the circulation, but infused directly to the arterial system to provide partial or complete circulatory or cardiac support also. And the degree of respiratory support is variable in this situation, And so this is predominantly done in the cardiothoracic unit and in the in the cardiac surgery unit, or in ARDS with septic shock, where you are requiring to maintain a blood pressure also. ACCO2R, or extracorporeal carbon dioxide removal, refers to gas exchange support. But as you can see here, the blood flow rates are typically much less, about only about a liter and a half per minute, which may be adequate for meaningful carbon dioxide removal, but not for oxygenation. And this is because of the property of carbon dioxide, as we know in native lungs also. Because of the high solubility of carbon dioxide, carbon dioxide diffuses across the alveolar capillary membrane as well as the artificial membrane at a 3 times faster speed than oxygen, as a result of which you require lesser flow rates to ensure that oxygenation happens. So the basic fundamental principle when we do an extracorporeal membrane oxygen is that deoxygenated blood is removed via a venous drain, carbon dioxide is removed, oxygen is added through an oxygenator or an extracorporeal device, and blood is returned to the systemic circulation via another vein or artery. And it can be either a VV or a VA ECMO, as we just explained. So if you were to look at the ECMO per se, and this one simple diagram kind of in a nutshell puts what is ECMO and what we are doing. So the first step is obviously venous withdrawal. That means the cannula is placed into the through in the right femoral vein, and the tip of the cannula enters just into the right atrium, as can be seen in this inlet. But the blood is withdrawn from the inferior vena cava. We don't want this a little down, because then it might enter into the hepatic vein here, and then that can cause problems of blood flow. So we want this tip right here in the inferior vena cava. Once this blood is drawn out, it is deoxygenated blood is drawn into the pump by negative pressure, and this pump will then expels the blood under positive pressure and drives it to the oxygenator. The oxygenator is connected to a mixture of room air and oxygen by varying fraction, like with an air oxygen blender, which you see on top of a ventilator also. And in the if you look at this oxygenator on the inlet here, you will see that blood flows into the oxygenator, washing over bundles of hollow fibers where actually gas exchange occurs. So this is the alveolar capillary membrane for all of us pulmonologists who are looking at this. This is how the gas exchange happens, that oxygen moves, diffuses in from its area of high concentration to low concentration, that is from the from this pipe, hollow pipe, into the blood, and carbon dioxide goes reverse from the blood into the pipe and is washed out in the system, and the exhaust gas goes it out, and this blood is then oxygenated, decarboxylated, and exits under an attenuated positive pressure. And you can see the color is not blue and red, but it's dark red and bright red as it comes out, and it is returned into the venous circulation again, into the right atrium, just at the tip of the SVC in the right atrium, directing towards the right ventricle and the tricuspid valve, from where it is just sent into the native circulation like the way it is usually done. So this is, as I said, this one is placed in the right, through the right internal jugular vein. So this is the simple one single photograph to explain the principle on working and where the various cannulas are put in, and what's the flow and what's the working reason for the pump, how does the oxygenator work and all. So this is what a physician really needs to know about ECMO. And a chest physician working, we really don't need to know the technicalities of how the oxygenator works. How do we know the oxygenator is working? So it's a pre-oxygenator blood gas and a post-oxygenator blood gas. What's the ratio? Sometimes the color itself is good, but a bare minimum 50 should be there, increase in PO2, to say that the oxygenator is working. Otherwise, we need to change it. But we normally expect an increase of almost 300 millimeters of mercury between the pre and the post oxygenator to know that it's working. There are many complications that can happen because both of these are together, and we as non people who are not actually inserting this and not troubleshooting it. So if a general physician or a pulmonary physician who's looking at the patient, who's recommending ECMO, need not get bothered with what are the various other things that happen. The complications that can happen by placement, by all these things. So the mechanism of gas exchange, as I mentioned, is just a simple diffusion as the blood oxygen flows across the through the fraction of delivered oxygen, which is called FDO2, and this is similar to the FiO2 that you can see in a mechanical ventilator. And the sweep gas, or the gas that is flowing from here, is what is responsible for the carbon dioxide removal. And so the faster the sweep gas going across, the faster is the removal of carbon dioxide. So it is analogous to the sweep flow is equal to the minute ventilation, and the FDO2 is equal to the FiO2. So in a simple way, that's what we convert. So the delivery of oxygen, because we are delivering venous blood back into the venous circulation, the best SpO2 that we can expect is 95%, but usually we see about 80% with a PO2 of 50. And we're very happy with this, because if you have a hemoglobin about 15, the oxygen delivery remains okay. And one of the ways we know that the initial patient's native lung is getting better is that if you are, say, ECMOing somebody whose SATs remain about 85%, and as the native lung improves and the amount of FDO2 remains stable or decreases, your SpO2 improves because your native lung is contributing much better. So the difference between the venous and arterial saturation actually reflects the contribution of the native lung that you will be seeing in this situation. So oxygen delivery, as we know, is a product of hemoglobin into saturation into 1.36, and is very lowly, not very significantly affected by the PO2. So as long as your hemoglobin is about 10, you're going to get a decent oxygen content. The ECLS guidelines recommend a hemoglobin of 12, but the critical care guidelines generally use 7 to 8 for most of our critically ill patients. But in ECMO, we tend to keep it around 10, and preferably between 10 and 12, and we transfuse to keep the patient around 10, knowing fully well the negative consequences of transfusion. But that's the only way we can keep the oxygen content adequate, and the patient's lactate will come down subsequently. The factors affecting gas exchange, as I said, includes the native cardiac output, the ECLS sweep and FiO2, the ECLS flow, the hemoglobin, and where your site of mixing of the ECLS circulation and native circulation, depending on what kind of ECMO you're running. There are various complications. We as a physician need to know, the person who's inserting need to know the cannula related complication, and cannula related bleeding is the most thing, because you're putting in really large bore cannulas to enter. You can even have, especially in the femoral, because you can have a compartment syndrome, you can even end up with a fasciotomy or amputation, limb ischemia. And you can have circuit related, the circuits can clot, there can be a failure of oxygenation, the circuit needs to be changed, there can be an air in the circuit, and there can be pump failure. Pump failures now with the modern ECMO machines are extremely rare, but still we need to be prepared for it, and then there is an issue with it. But the main medical complication that we nowadays see is obviously increased creatinine, which is an acute kidney injury, is about 20%. We do see obviously the feared complications are neurological, that you bleed into your brain, and that's still about all CNS hemorrhage is about 3.4%. You can have a pneumothorax, you can have pulmonary hemorrhage. That's more related to the fact that the lung is not getting better, rather than the fact that the ECMO is doing it. You have sepsis, which is the biggest problem in our country, where maintaining a circuit in beyond 7-10 days becomes a significant burden. And once you have infection, it's almost like an endocarditis. It takes a very difficult to clear it. Hemolysis and DICs used to be a major burden in the past with the old thrombogenic filters, thrombogenic pumps. But now with the modern non-thrombogenic pumps, this is a less and less of problem. Obviously, anticoagulation related problem again is bleeding, and this is something which is GI bleed, pulmonary hemorrhage, cannula site and surgical site bleeding are there. And we try to maintain an ACT of between 180 to 200 nowadays, than anything higher, 250 and beyond, to prevent this from happening. So what is the clinical evidence? We know we've been doing this in COVID situation and this thing. But if you look at it, the initial first success story was in 1971, but then subsequently there were two major randomized controlled trials in 1979 and 1994, which kind of put ECLS out of business for acute respiratory failure, and mechanical ventilation won the hand. So looking at the 1994 Morris's study, which was a negative study, you looked at 40 patients with severe, and they tried only pressure control inverse ratio ventilation, followed by veno-venous ECMO, or to conventional ECCO2R, and to conventional mechanical ventilation. And this was stopped early for futility with no survival difference. Again, this is at this time in the technology wise, the bleeding in the extracorporeal group was the one which was related to the poor outcome, and that's why it was stopped. And this is an intensely thrombogenic circuit, and these have really changed. And so this has really gone. I don't think we should look into a data from 1994 as far as technology is concerned. Again, the second inflection point why ECMO became popular was the Caesar trial, which was published in 2009. We'll discuss that a little bit. And of course, the influenza A H1N1 epidemic that happened in 2009. And obviously, the second inflection point that we are now seeing is COVID-19, where the use of ECMO has again gone up significantly. So, if you look at the Caesar trial, which was basically looking at extracorporeal membrane oxygenation, it assigned 180 patients with acute respiratory failure to undergo at a single ECMO center. But remember, this is not a trial of ECMO versus no ECMO. It's a trial of transfer to an ECMO center versus continuing in the same center. So this is a huge paradigm shift. And even in that situation, they're looking at a significant mortality difference of 63% versus 47%. But you have to understand that 75% of patients who were transferred only to the ECMO center got ECMO. The remaining 25% were managed without an ECMO in the centers. So it just goes to say, and they were also comparing a non-lung protective lung ventilation to a great extent, comparing to a ECMO center which is doing lung protective ventilation. So there were some controversies regarding this, but the H1N1 epidemic that happened subsequently and this trial there really gave a positive fillip to the use of this. As I mentioned, in the ECMO centers, the H1N1 time, the mortality was 23.7 versus 52.5% in the non-ECMO group. So as a result of which, there's a significant push for the use of ECMO in this kind of a situation. The goals of ECMO have changed. Over the initial years, it was the other reason why things have been a push for ECMO and respiratory failure is the initial goals were to maintain adequate oxygenation, and the hypothesis that people were dying from severe hypoxemia with high lactates and multi-organ failure. However, it has become clear that the major cause of now we know that it's ventilator-induced lung injury or VLI, and the ventilator support itself which is responsible for the issues, and therefore we tend to have a little bit more goals. The goals have changed from minimizing hypoxia, which will obviously increase your PaO2 and decrease the tissue hypoxia, which will still happen with ECMO. But the more thing is that you have minimizing hypercapnia, which will decrease the respiratory acidosis, decrease the right ventricular. If your acidosis goes down, your right ventricular afterload goes down, and your cardiac output improves. Similarly, your lung stress and strain goes down, so you're able to decrease your tidal volume to almost 4 ml per kilogram, even sometimes even less. Plateau pressure goes down. You can easily maintain everything below 22. Respiratory rate can be brought down to just 10 per minute to 14 per minute, and the driving pressure can be kept less than 14 at all times. So as a result of which, all kinds of ventilator-induced lung trauma, not only these four, but the power ergo trauma as well as the will be decreased as a result of it, and there will be less multi-organ dysfunction. And obviously, you're keeping a patient more awake, and you're not paralyzing them, you're not deep sedating them, you're just leaving them on light sedation, and you'll improve the diaphragmatic working. So overall, in all, you will see a significant physiological benefit for ECLS in respiratory failure, which is not will be seen only will not be seen with mechanical ventilation. So that's the push for this thing. So as of now, based on the various studies, the application in clinical medicine is for very severe ARDS, and I'm going to talk about that in the earlier trial. It's there for moderate ARDS only in a research basis, but we tend to push it nowadays a lot more because of the huge push, and we need to be careful in this group. Bridge to lung transplantation. We have patients going in post-COVID fibrotic lung who have been transferred to lung transplant centers on ECMO. Graft dysfunction after lung transplant, and there's the research is obviously COPD, asthma, massive pulmonary embolism, and pulmonary hypertension decompensation is all clinically we are doing it. But these are all case series. Well, for these there is evidence, and I'll show you these evidence in a bit. So for very severe ARDS, the clinical evidence comes from this earlier trial published in New England Journal of Medicine in 2018, multi-center international RCT in patients with very severe ARDS. They define very severe ARDS. I'll show you the definition. Your PaO2 has not to improve despite proning, despite maximum more than 80% of ventilation, more FiO2 more than 10 of P. And you have to have a PF ratio of less than 80 for more than 6 hours or less than 650 for more than 3 hours. And we'll talk about that. And so they looked at it, but again, the recruitment was very slow. The trial again was terminated early for futility, non-statistically significant, yet large reduction in mortality, 35% versus 46%. And 2 deaths attributed to ECMO, and transfusion-related complication of bleeding was there in the ECMO group, but overall rate of complication was much, much less as compared to in the previous past. So after the earlier trial, there was a post-hoc Bayesian analysis of this earlier trial, which also suggests there's a mortality benefit to ECMO in very severe ARDS, as defined by this criteria. That means your PF ratio is less than 50 for greater than 3 hours or less than 80 for greater than 6 hours. and your pH is less than 7.25 with a PaCO2 greater than 60 millimeter. That means you have gone from permissible hypercapnia to impermissible hypercapnia, and you have had for more than 6 hours with a respiratory rate at a maximum of 35 per minute, adjusted for a plateau of less than 32. So with all these criteria, you will find that it is a problem. In COVID, I didn't really like the ECMO criteria because we tried them on BiPAP, HFNC for many days, and they were looking at really a kind of an organizing pneumonia or a fibroproliferative ARDS in which we were trying to do ECMO, and that's why the results were only good if you were to do them early and when they are in this kind of situation in the first 7-10 days of onset of illness, and they have not been ventilated for less than more than 7 days. So this is what we were happening, was that we were mechanically ventilating them, but with an NIV for more than 7 days, and then ventilate and then consider them for ECMO, and that's when the outcomes are not really good. So if you follow these criteria, then probably the very severe ARDS do very well with ECMO. So we really know that it works. But moderate to severe ARDS, again, hypoxemia is not so severe, so preventing villi is the aim, and lung protective ventilation can be used. So in this situation, ECCO2R may have a role if there is impermissible hypercapnia. Again, the evidence for this with the extravent study is not shown any significant benefit. Significant reduction, if your PF ratio is less than 150, then there might be benefit for ECCO2R in moderate to severe ARDS, but that is less than 150 PF ratio. But again, this is still a research thing, and we are not recommending that we put patients on ECMO. And this is one of the things that has happened, is that a lot of patients during the COVID got into ECMO proper for moderate to severe ARDS and not for very severe ARDS. And the other thing is obviously bridge to lung transplant, and there's no other way. Initially, it used to be traditionally thought that once you're on ECMO, you're a bad candidate. But now it says that ECMO actually gives you much more ability to do physical therapy, improve your nutrition, decrease your sedation, make you mobile, and then go ahead and do lung transplant. So you're probably better off on an ECMO rather than without an ECMO. And this is obviously in clinical practice now in all the lung transplant centers. In acute exacerbation of COPD, where it makes intrinsic sense to do ECCO2R, that is extracorporeal carbon dioxide removal, the evidence is not there to help that it actually works, and so therefore it is still a recommendation which is only in research activity and not a clinical recommendation. The other things which are in clinical practice, of course, in which there will not be much evidence, is because these are few in number and far in between, is right-sided heart failure with or without respiratory failure, and these are pulmonary embolism and acute decompensation of pulmonary hypertension. In this situation, we know arterial ECMO is required either with treatment, with surgical treatment like surgical embolectomy, or with anticoagulation alone. Both have been tried for VA ECMO in pulmonary embolism. And similarly, a decompensation of a chronic pulmonary hypertension for whatever reason may also be managed by this thing, as long as you use it as a bridge to transplant and a bridge to recovery. And this has been also into clinical practice has been established. So there are very few contraindications for us physicians to know. The only absolute contraindication is an irreversible underlying process. A relative contraindication is obviously a moribund state. You've gone for more than 7 days on mechanical ventilator. You are devastating neurological injury, untreatable metastatic cancer, and mostly common sense, I would say. And difficult vascular access is for the technicians to say, for the cardiac surgeons and the people who help us put in these things, to say that we cannot put an ECLS in. We cannot do an ECLS for him. Obviously, there is a significant financial and ethical implication. So that's why we need to be aware that its average cost is about 5 to 6 lakh per week, and the median time that most of our ECMO patients require is anywhere from 12 to 18 days is what we will require ECMO for. So that means you're looking at 2 to 3 weeks. So that's looking at almost 15 to 20 lakh of rupees. In addition, because of the cost goes up, not only because of the number of ACTs, number of ABGs, the close monitoring, but also because the dosing of antibiotics, dosing of various medications also goes a little higher, and it also increases the cost. And then infections are a significant issue in these things. Although there are key ethical issues also that are raised by the ECMO ECLS, and that is is it appropriate to withhold ECLS when patients are dying with this acute respiratory failure, and when to withdraw ECLS when the goals of care can no longer be met. So you put an ECLS and you're not able to wean them off the ECLS. How do you take them? How do you decide to go about withdrawing in that situation is a big thing which we need to grapple, because it's even more expensive than a ventilator, where even continuing ventilator for a day hurts the family. Continuing ECMO for a couple more days in the presence of a poor functional recovery is going to be another ethical issue that we're going to be playing with. So, this is a brief, quick summary of 15 to 20 minutes about what ECMO is in acute respiratory failure. This is a wonderful editorial that followed the earlier trial, and I completely agree. We all know ECMO works. There is no doubt about that. That question has been put to rest from 1971 onwards. It's just that we don't know which respiratory failure. After the earlier trial, we probably know, at least in acute respiratory failure, it's a very severe ARDS. If we use the criteria as outlined in the earlier entry criteria, we probably would be selecting our patients very well, and we would probably be able to do justice. So that means your PF doesn't improve to more than 80 after 6 hours, or less. That remains less than 50 after 3 hours of proning, 80% FiO2, best optimization of your mechanical ventilation, and so on. So the question that remains to answer is, by how much does it acquire? 36 versus 45%, it's a huge difference, but in outcomes, in mortality, is it good enough that we spend so much money? In whom does it work? Can we check our patients? I think it definitely does not work in the fibrotic lung unless it's a bridge to a transplant. And at what cost do we invoke for these kind of patients? So 15 to 20 lakh as a bare minimum, and the average cost of them getting out of the hospital is about 25 to 40 lakhs for a majority of these patients with acute respiratory failure. So at what cost is what is the main issue when we start doing things which are extremely labor intensive, but obviously it is technically invasive. It is an invasive procedure to the best possible, because you're taking the heart and lungs and getting it out of the body, and doing it for days and weeks if it required. So I will just end here saying that we definitely need to have a better understanding of when to start ECMO, and we need to stick to the EOLIA entry criteria, and to understand that we probably need to be a little bit more careful in selecting, and we need to be aware of the cost implications of this. Thank you very much for your kind attention.